Good morning, Max.
Good morning, Fran. How are you?
Fine, Max. You look very healthy.
Well, thank you. So do you. It's nice to say hello to you.
Yes,
And
yes, yes.
things have been going well for you, I hope. And
Yes, in general, yes, everything is fine. But the community and the hospitals still have a lot of burden now because of the pandemic. How
because
is
of
it?
the
Yeah.
coronavirus.
Yes,
Yes.
because of the coronavirus.
Yes.
I
Good
think
morning.
in America it's worse than Indonesia. I don't know. I mean, the
Uh-huh.
death toll is very high in the states.
Where, Fran?
In your place.
Yes, that's right. I think New York and Illinois is not so bad, or Chicago, but
Mhm.
New York is probably the worst spot in the U.S. But some of the virus is coming, or more people are getting infected again. So I'm not sure if there is going to be a resurgence or not, to be honest. So it's a
Mhm.
very serious consideration.
Yes, yes. But how about in your in Chicago? Is it how is the condition?
Chicago, I think Chicago and the governor, the mayor and the governor have done a good job.
Hmm.
And so Illinois, Chicago, the city is not. I think it's average at most,
Hmm.
and we are still under restrictions.
Hmm.
Our museum is still closed. The restaurants are not open except for outside dining, but inside dining, no. I
Hmm.
think on next Monday, the
Hmm.
22nd,
Okay.
Chicago time, a lot of the businesses will reopen in Chicago and Illinois.
Hmm.
And so I think hopefully it will go well.
Hmm.
But so Chicago has had an average, not the highest, more than some other areas, but I think it's been a reasonably uh, not as bad as New York and some places.
Yes.
But
So,
again, the reinfection rate can be can be very challenging.
oh, you have
So,
you have a lot of cases of reinfection. I mean, people already cured and then get
well, in some states, not reinfection. That's probably my word or bad word, but it means that the infections and deaths went down,
mm-hmm.
and then they
It's
are
going up again.
increasing again,
Yes,
but
yes.
not necessarily the same persons being
Okay.
reinfected.
Okay.
Yeah.
Okay.
Good
Sorry
morning,
about that.
Max.
Yes.
Good
Good
morning, Dr.
morning.
Peter.
Hi, Peter. Good
Hey,
morning,
good
Peter.
evening. Special
Dr.
for
Vivian.
Max. Good
Morning.
evening, Max. Yeah. Good
Yes.
morning, Dr. Franz. Good morning,
Morning,
Dr.
Dr. Peter.
Dwirani.
Yeah, Dr.
Good.
Vivian.
Hi.
Hello.
Good morning, everyone.
Hey.
Hello, Matt.
Morning.
Morning.
Morning,
How are you doing, Max?
Dr. Handy. Good morning.
morning, morning, everybody.
Morning.
Morning, Dr. Handy. Prof. I'm sorry, Prof. Prof. Handy. Okay. Dr. Peter, we will wait up to 8 o'clock. Dr.
Sorry, Dr.
Peter.
Franz.
Yes.
Please say it again.
We will wait to up to 8 o'clock, right? For the participants.
Yeah, but I think after the session. You mean after the session?
Hmm? No. I mean, now we are currently waiting for the participants, right?
Yeah.
Okay. Okay.
Max, responding to your request that the host will run for your slides, you
Okay.
just
Thank you.
tell the host next or back, okay?
Okay. Thank you so much. That's very kind. I,
Okay.
I can pull them up myself, but I would prefer that you folks do it. So thank you.
You're welcome, Max.
Um,
Good morning,
Max,
Prof. Hendy.
how are you, Max?
Morning,
Hi.
Peter.
Good. Hi,
Uh,
Morning, good
Professor
night.
Tahalele.
Good night.
Yes, good morning, Professor Tahalele. Good to see you.
Thank you for your participation. As a
Oh, it's
speaker.
my
Yeah,
honor and
that's
privilege.
fine.
So thank you. It's nice. It's really my honor and privilege to be able to participate with you. So I'm very very appreciative. Thank you.
Okay, thank you again. And maybe next time, next month, we will invite Professor Giorgio Solfas as a
Yes,
speaker. Yeah,
he would like that.
and we try to organize this webinar, International College of Surgeon Surgical Forum
Well,
webinar. Yeah, that's
I
good.
congratulate you. I commend you. I think that what you're doing in the Indonesian section is absolutely wonderful, and I hope that other sections will copy what you're doing. I think it's the future, certainly part of the future, and so I really congratulate all of you for this type of virtual seminar and a virtual meeting. It's fantastic, and I do hope other sections will follow your lead.
Okay, thank you, Max, for your support our organization.
Okay.
Yeah.
It's my pleasure. I work for you. I work for all of you, and it's a pleasure to serve you. So thank you.
Uh-huh. I just talked with Professor Kwan, and I invite
Yes,
Professor Kwan to join to this webinar meeting.
wonderful. Is she
Yeah.
going to join?
I hope
Will she
I
join?
hope she is
Yeah,
she has a time and then join with us.
wonderful.
Yeah.
She's a great lady, and she's an Indonesian.
Yes, of course.
Yes. So
He's born in East Java, Jember.
yes,
Jember
yes.
City. Yeah. And maybe Professor Sulfas is there because we
I'm
invite
sorry.
also Professor Sulfas come to this.
Is he on? I hope.
Yeah, I don't know. Mungkin Peter is there.
I don't
Yeah,
think.
I'm here.
No, Prof. Sulfas is not here yet, Professor Paul.
Oh
So
yeah.
yeah, I'm checking the participants, and I don't see Professor Sulfas here. I think.
Dr. Franz, thank you very much.
You're welcome, Prof.
You helped Dr. Peter and all the organizing committee. Professor Handy, welcome. Good morning.
Morning, Prof. Paul.
Professor Dwirani.
Thank
Yeah.
you. Yes, thank you very
Oh,
much.
Morning.
sehat. Yes,
Are you happy and healthy?
yes, we are.
Coba diambil fotonya. Ada ininya.
We will start at some minutes. Yeah,
Yeah, okay.
yeah, maybe 5 minutes left.
Yeah, we wait for that. Maybe Max, you have a suggestion for our society
Um,
because
in
during the pandemic time we have a very limited activity and stay at home and work from home. There's all the campus is closed, and now we begin with worker the president um, open step by step this
yes,
lockdown time.
yes. It's very similar, Professor Tahale. In Chicago, I was talking to Dr. Arifins and others earlier. The in fact, the businesses are opening up to some degree. Next Monday, June 22. But during the pandemic, I came to the office every day because there was no one here, and it's about a mile away. And so I was safer in my office than I probably was in my condo. So in terms of the college activities, the membership and website and journal activities continued, really not dependent on having being inside the office. So The museum, on the other hand, was closed. The museum has been closed for about 3 months, and it appears that we will not be able to open until later June or early July. So the museum has been shut down, and of course, it's very important to the college. But the membership, the website development, and the journal really continued with some slower rate of activity, but we kept busy and we kept going. So I think that in terms of activities of the college, we continued. And of course, we continued to speak with the governors, Professor Sufas and others, as you know. And so the college activities didn't stop. We kept going.
Yeah. I think it's a very good job that you do on the remaking of the website. It's
Thank
more
you.
informative and easier to understand. So
Thank you so much.
it's an excellent remake of the website.
So thank you.
Yes.
The website is really brand new, and
Yes,
we
yes.
launched it in January,
Mhm.
Franz, and
Yes, yes. I,
it's and it we knew there would be many advantages, but quite honestly, I think we're finding there are even more advantages than we envisioned. And
yes,
it's an
yes,
ongoing, it's a work in progress.
yes.
And so we continue to work every week, making
Mhm.
improvements and so forth. But
Mhm.
thank you for your comment. It's good to
Yeah.
hear you and others say that because
Yes.
you're the final judge. So thank you.
Yeah, I think we might put links to our collaborators like the WHO link and the G4 Alliance link there.
Yes.
So it might improve the traffic to the website, to our website.
Yes.
Yes.
Okay. You're suggesting we should have better links?
Yeah.
Yes. Yes. I think you're right.
Mm.
G4
Yeah,
and
G4 and WHO.
yeah, WHO. Thank
Yeah.
you, and we will see to that.
Yes.
Those are good suggestions.
Yes,
We
thank you.
publish the WHO newsletters
Yes, I see.
on the main site,
Yeah.
but I think the linkages are very important, and that's a good idea. Thank you.
Good morning, Professor Wiyadi, ENT surgeon. I see Prof. Wiyadi here. Good morning, Professor Wiyadi. Professor Wiyadi. Okay. Can we start now, Professor Paul, Max?
Yes.
Okay.
You wish me? Go ahead.
Yeah. Good morning, everyone. I am Peter Johannes Manopo, General Surgeon, FICS. I will be the moderator this morning. And first of all, I would like to welcome all participants to this webinar. The International College of Surgeons Indonesian Section Surgical Forum Chapter 4 this morning. First of all, I would like to express my gratitude and high appreciation for all participants, particularly our guest speakers, Mr. Max Downham as the Global Executive Director of the International College of Surgeons. Thank you, Max, for your willingness to participate. And to the President of the Indonesian Section, Professor Paul Tahalele, FICS, Cardiothoracic Surgeon, Professor Hendarto, Obstetric Gynecology Surgeon, FICS, Dr. Franz Arifin, Digestive Surgeon, FICS, and the speakers, Dr. Vivin, Dr. Dwirani Rosmala Pratiwi, breast surgeon, FICS, and then Dr. Bastu Hermendy, ENT surgeon, Dr. Tauhid Islamy, obstetric gynecologic surgeon, and all participants. So in this opportunity, I hope that there are also international participants, but so far, I think maybe later on, yeah, I see here only Indonesian participants so far. All right, the first opportunity, I would like to invite Professor Paul Tahalele as the president of the Indonesia section to address his opening speech. Professor Paul Tahalele, the floor is yours.
Thank you, Peter. Greeting from ICS Indonesian section. Good morning, good afternoon, and good night to all ICS members, friends from all over the world. Welcome to this International Surgical Forum, International College of Surgeons. Today is the first time for our held this international webinar seminar meeting, and I hope it will be a success. And thank you for the organization committee, Dr. Peter, Dr. Sudara Bimo, Mr. Bimo, and I welcome to every participant, all of our members, all over the world. And you know the pandemic era is make all. Next slide, please. Next slide, please. Next slide. What is a new normal era? New normal is a term in business and economic that refers to financial condition following the financial crisis of the 2007, the 2008, and the aftermath of the 2008 until 2012 global recession and the COVID-19 pandemic. Now we move to the new way of living after COVID-19 pandemic in surgery fields. Next slide, please. Our routine life are changing. Therefore, we have to readjust our habits and our approach to overcome all the conditions caused by COVID-19. Now we must prepare to enter the new normal era. Please, are you ready? As a surgeon, I work in the operating theater. This situation is not convenient for us. And of course, we must prepare several requirement and questionnaires. We must follow the WSO guideline because our routine life totally changed. Is your institution and society prepared for the new normal? There are great uncertainty and more rapid change than ever before in our life. Clearly, COVID-19 has brought about huge change in society, consumers, businesses, including in medicine. And at the same time, we are moving through what is often called Industrial Revolution 4.0, and we move rapidly into the digital era. Next slide, please. And I cited several statements from the 11 spine surgeon from the United States, Professor Colt Kim from San Diego, COVID-19 crisis is devastating, merusak semuanya. Kemudian next Professor Richard from Washington University, we are uncharted territory. It's clear we will not return to the old normal. And Professor Andre from the New York City, he mentioned about we will be less outpatient and surgical volume until there is a vaccine, truly effective drug or herd immunity. And the next is, I think this is Professor Scott from Atlanta. It is reality. We need proper personal protective equipment, screening, and hygiene, and enable all healthcare facility to remain COVID-19 safe. And the next slide, the last slide. Thank you very much. Have a nice day. See you in the next international webinar of ICS. And the next speaker is, we'll invite Professor Georgios Solvas as a president of International College of Surgeons Global. Thank you very much. Thank you, Mr. Max, for your participation, and have a good time.
Yeah.
Thank you.
Thanks, Prof. Paul, for your speech. And the next opportunity, I would like to invite Professor Hermendy Hendarto, obstetric and gynecologic surgeon, as the Vice President of the Indonesia section. Prof. Hermendy, the floor is yours.
Thank you, Dr. Peter. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. To President of ICS for Indonesia section, Prof. Paul, thank you very much for your excellent presentation. Yeah, I think we all, especially surgeons, must know about the new era and adopt this procedure, new procedure maybe. And to all speakers, especially guest speaker, Mr. Max, thank you. And to all participants, welcome and thank you for joining Surgical Forum Chapter 4, International College of Surgeons Indonesian section. I hope we all stay healthy and keep high spirits of working hard in this pandemic. And ladies and gentlemen, as we know, ICS is a long history. There's now it was at the first established, now it's about 85 years, I think. The college is open for all nationality and all races and all regions. And up to now, college has a member more than 100 countries, including Indonesia. We know ICS is a home for surgeon, and also ICS is a scientific community that has mission to develop worldwide surgical excellence through the education, training, fellowship, and humanitarian work. Today, we have a program of Indonesian section. We have several potential speakers from different disciplines of surgery. They will talk about their experience in surgery. And as we know, surgery is a medical specialty that uses operative manual and instrumental technique of a person to treat pathological condition of disease. And if we talk about scientific in the surgery, especially now we enter in the new normal era, of course, something changed in surgical procedure or environment of surgical during this pandemic. But we still hope that all surgery still continue to provide best surgical treatment for the patient. And finally, thank you for all speakers for sharing the experience, and to all participants, have an interesting discussion. Thank you very much for your attention. Thank you.
Thank you, Professor Hermendy, for the scientific notes. For the next opportunity, I would like to invite Dr. Franz Arifin as the secretary for the business notes. Dr. Franz Arifin, the floor is yours. Dr. Franz?
Thank you, Dr. Peter. Just a moment, I will share my screen. Okay. Is it there? Is it showing the screen? Is my screen showing, Dr. Peter?
Yes, it's,
Yep.
I see it.
Oh,
Yeah.
okay.
Yeah.
Okay. Yeah. Okay. Thank you
Your
for
slides is clear.
the time. Okay. So actually, there are four topics that I would like to update on the business section. The first is about the International Surgery Journals. The second one is the exhibition on the International Museum of Surgical Sciences. The third is about the WEPI WIN COVID update, and as you know that the ICS is collaborating with the WHO on the COVID pandemic, and the fourth one will be the launching of online survey for our members on the implementation of a new normal in surgical services. So I'd like to start on the first one. This is the International Surgery website. It's an open access website, so everybody can see the published journal here. And as you can see, it is still publishing, although not in the printed form. But the volume is less updated on 2019, but the online first is still running. So if anybody wants to publish in the International Surgery, our ICS journal, it can be published online first, which means that will be included and can be shown in the website before it is included in the volume of the issues. You see, the last published is on the 2nd of June 2020. So it's continuously updated. The second one is about the International Museum of Surgical Sciences. So as you can see in the slide, there are two virtual exhibitions. So if even we cannot visit the museum personally, but we can see some of the exhibit there. One of the interesting one is about pain. So all the members can visit the website imss.org, and you can see some of the exhibits that was presented in the museum virtually. The third one is update on the coronavirus. So there are two different updates. The first one is the AP-WIN, which is a shortened version of the regular updates on the COVID-19 by the WHO. This is on a format of slides, so it is a very shortened version, and it is not updated as frequently as the epidemic report. So, but this is the last one, 5 of June, update number 29. The top 10 countries in the past 24 hours is Brazil up to the 5th of June, USA and India. I think we should be grateful that Indonesia is not there, hopefully, never be one of the 10 biggest case. But currently, with the latest update, I think the number of total cases globally is reaching 8 million, because in the last week, United States contribute about 1 million new case. So it's rapidly increasing in some of the countries. These are the information resources. So everybody can use the WHO WhatsApp messaging service. Just enter the number, which is shown in the screen, and then text hi, and then you get a menu of updates on the WHO. whether it's the statistic or whether it's the guideline update. So I suggest that every ICS member keep an update on the COVID-19, especially the guidelines on management and the guidelines on the prevention of infection. By the WHO region, this is the one that the CITRAP, which is called the situation report. This is the updated daily. So as I mentioned previously, globally now there are more than 8 million cases, and the Americas and the European WHO region is the most hardly hit. The last one, I hope I do not take too much time. So in the next week, ICS Indonesia will launch an survey, an online survey using Google Form, and it will be distributed on the ICS group, WhatsApp group. So there will be some questions and multiple choice questions and about these variables. We would like to know the condition and how ICS Indonesia can support in the next new normal, as Professor Paul mentioned. So it's kind of a need assessment and also about report of the condition of surgical services. In the surgical services, it is not only the surgery that matters, but it's also including the supporting specialists like the pathologists, the radiologists, and everyone who are involved in the OR team. So this is the schematic of the survey. As you can see that the timing during lockdown, I think we don't have a lockdown. It's just a shortened version. So it means it's during now, the condition that is the surgery is limited, and what we will expect to see and to work in a new normal era. And the input will be about the surgeons or other specialists that was involved, and also the hospital system, because as you know that surgery is not a simple procedures. It needs a complex organization and maintenance of equipment and resources. The third one is the process. The process indicators will include the provider safety, the safety of the surgeons, and patient safety. How do we put the safety of our candidates, our surgical candidates, safe? And for the output, two main criteria that we will put in the survey is whether we have an increased risk of mortality or morbidity for the patients that have COVID-19 and have surgery, and we will see what is the surgeon experience on these matters. So I think that is all, Dr. Peter. I hope that all the members will participate in the survey so we can all see what is happening, and we can expect to anticipate the new normal in Indonesia. Thank you very much.
Thank you, Dr. Franz Arifin, for your business session. And now we come to the scientific session. And for the first opportunity, I would like to invite Mr. Max Downham to deliver his presentations. Mr. Bimo, please help to run the slide of Mr. Max Downham. Mr. Max Downham, the floor is yours.
Well, thank you, Dr. Manopo, and I am very privileged and honored to be a part of this process of this virtual conference, and I really commend all of you, Professor Tahalele, Dr. Arifins, Dr. Hindi, and all of the other leaders of the Indonesian section for doing this. I hope that other sections will follow your lead and duplicate what you are doing, because I think it's fantastic. And again, I'm honored to be part of it. My remarks are made on behalf, and I'm going to look at my watch, Dr. Manopo, so I don't overdo the time. But I'm speaking on behalf of Professor Giorgio Soufas, the world president, the other leaders of the International Parent Body, one of whom is an Indonesian world president-elect, Professor Ali Kwan. And we look forward to her leadership or continuing leadership, which is wonderful. Professor Ho in Australia and others. So I really am appreciative of being a part of this process. I don't know if the slides are up yet or not. I don't see them on my screen.
Mr. Bimo, please expose the slide.
And while we're waiting, I noted, there it is. I noted that, thank you, that Professor Tahalele's remarks, absolutely correct. The new normal, I suppose in a way, in general, there is no status quo in life or in surgery. You either progress or you regress. And I think that this conference is all about progressing. And so really, again, very proud of all of the Indonesian fellows and what you're doing. It's been, again, my privilege to work with Professor Tahalele, who's on our board of directors, generically, or International Executive Council. We're very proud of Professor Tahalele and also Dr. Arifins, I know, Dr. Hindi. So we're proud of all of you in Indonesia, and we hope that you keep up your great work. But we really are very proud of you. So the next slide, please. And by the way, Dr. Manopo, I changed the title to the present and the future, and deleted past because, as we say in American lingo, it is what it is. It's done. It's over. It's of no value to spend time on the past. So I'm talking about the present and the future, where we're headed. We just posted 2 or 3 days ago on the ICS website this statement. It's a statement of the International College of Surgeons. And we posted it with the help of Professor Soufas, Professor Ho, our General Counsel, Leon Edelman, and other people at the headquarters, Jennifer Tron, Patricia Benfa. We posted this because of the turmoil that's occurring not only in the United States, both because of the virus as well as, I think, the demonstrations about inequality and so forth. And we thought that we should post this statement. And I believe that one of the other, Dr. Hindi, referenced this, I believe. The fact of the matter is that the International College of Surgeons, as he indicated, is 85 years of age. It was founded and based on the ideals of Dr. Max Thorek 85 years ago in 1935. It's really a statement of what we are, what we stand for, what are our values. And generally, in my experience, the briefer these statements are and the fewer the words, the better, because it's a constant compass as to what you are and where you're going. And the important things here are that for 85 years, the college has been open to all nationalities, all races, all creeds. We're apolitical. We don't lobby U.S. Governments of any kind anywhere in the world. And 85% of our membership is outside of the United States. I think those are the key aspects. But the key point I want to make here is that the ideals, the philosophy that Dr. Max Thorek had and that he developed 85 years ago, in my mind, are as true today, really even more true today. than they were true then. And so they are long-lasting ideals that are reflected in humanitarian surgery. The wonderful work that many of you have done in MBAN with Professor Ali Kwan and others. And so that's what we are. We stand for that. And we are not interested in a lot of the differing philosophies, governments, and so forth. We are apolitical. So with that, I'll go to the next slide, please. Actually, I've said this, and I've got a lot of things to say, and I don't want to go over time. So that's the words I've spoken there. But this is what we are. This is what we stand for. And in my words, each philosophy has its own beliefs and so forth. But in my words, the more you give, the more you get back. And the International College of Surgeons has the absolutely wonderful opportunity to give in the form of humanitarian surgery and other services to humankind. So with that, next slide, please. I'm going to talk briefly about the ICS website and really combine that with membership of the college because, and I want to thank you, Dr. Arifins, for your kind comments before we began the session this morning in the sense that we have a new website that was really launched in January of this year. It's brand new, it's interactive, it's a members only section. And so it's allowed us to streamline new applicants processing, e-commerce, member engagement, and the reinstatement of dropped members. So I'll touch briefly because I don't want to go over time here. So next slide, please, and we'll go kind of fast.
Excuse me, Max.
Yes.
You can talk for a moment without slides because Mr. Bima will update your newest slides.
Okay, these are, I think, pretty fairly current. So the member only, okay, I'll just keep talking. The members only portal is something that is new to our website. It allows, for example, the Indonesian members to go into the website, to look at their profile, and to edit the profile and update it. And you can see what your status is. If there are errors, you can correct it, and so forth. So the members only section is a very productive and very helpful, and it's personalized for each and every, for example, Indonesian and other fellows around the world. You can't look at your associates. It's only strictly for you, but it is a members only section, and we've just really only begun. The next slide, please, if you have it there. Maybe I'll just keep going. And you can see the status of your payments and so forth. Then going to the next slide, which is new applicant process improvements. The process for approving new applicants is, for example, in Indonesia, if you have a new member who applicant, what we do or what you do if the member comes to Professor Tahalele or Dr. Arifins or others of you, that member is approved or disapproved by the Indonesian leadership. The international parent body, the headquarters, has nothing to do with it. And so if, on the other hand, we receive in headquarters a notification via the website that there is a person in Indonesia who wishes to join the ICS, then what we do, again, we do not make the decisions on that. We simply send it to the Indonesian leadership, and again, the Indonesian leadership, the section leadership, makes a discussion or makes a decision on it. So we have streamlined that process for countries not pertaining, but for countries. Next slide, please. You're back, maybe. No, you have to go the other way. I can pull it up myself probably, but I was going to follow you. So in terms of new member processing, we've streamlined that with the website, and it's helping our membership as well. In terms of e-commerce upgrades, we're doing increasing numbers of sales of admittance to the museum, in the gift shop, and so forth. It helps with that. We're doing a lot of targeted advertising and promotion, and we are refining. It's an ongoing process, the search engine optimization, which, as I think all of you know, it drives people who go to our website, icsglobal.org, and then it drives people to that website if they're looking for certain things. I don't know if you're with me, or you can advance the slides or not.
Mr. Bimo, next slide, please.
Yeah. Next slide, please. Next one, please. Next one, please. Next one. Next one, please. Okay, and so as Dr. Arifins, I believe, was explaining about your survey, we're going to do a survey as well. And so I'll make a little deal with you, Dr. Arifins, if you'll share the results of your survey with us, we'll share ours. But the real key thought here is that the opinions of you, the members, are most important. As I said early on before we started the conference, we work for you. I work for all of you. You don't work for me. And it is important for us to know why you joined and why you stay, and what value, what services do you like, and what do you not like. And so next Tuesday or Wednesday, it's already set, we will send a survey to all ICS fellows around the world. It's what we call, Dr. Arifins, a monkey software, monkey survey. It tabulates the answers, and so I'll share that with you, regardless as to what you find, and happy to share it and have you comment on it. We're also then, about maybe a couple of weeks after next week, we're going to do the same kind of survey on international surgery. In fact, I've talked to Dr. Arifins a few weeks ago, I think on the phone, as I recall. I can't remember exactly when, but about publishing or having more manuscripts submitted from the Indonesian section for publishing in international surgery. And we have soon a new website, hosted website for the international surgery that will really become live in early September. So we are progressing. I'll have a few more comments about the journal later. Next one, please. Next slide. And here is a really key aspect. We have not only the active members of Indonesia in our database, but we have some of your other members who did not continue for one reason or another. And we have conducted a couple of trial letters to the drop members. We have, to those that we have email addresses. And in the past 3 months, we have, I don't know if you think it's big or not, but we've obtained about 25 new members, our re-engaged members who received our letter. They registered via the new website, and we want to do more of that. And I think that I would encourage the Indonesian, the active members, to take a look at that and see what you can do. But it is working for us. It's not, as I say, very truthfully, not a big number, but we're learning and we're refining that. So next slide, please. Enough on the website and members, and I'm looking at my watch. I'll go fast, but as has been referenced already, the relationship of the International College of Surgeons with the World Health Organization is a very special relationship that goes back 30, 40 years. I spend a lot of time nurturing that relationship, taking care of it, because it is one of the most valuable assets that the college has. We are in official relations as a non-governmental organization or NGO, and that is a coveted relationship that not everybody can get. In fact, I think we are probably the only general surgical society that has an NGO relationship officially with the WHO. Other organizations, some I know in the US, very big organizations, I won't mention their names, but they've been trying to get it, they cannot. Perhaps they will. But it provides us with status, it provides us with contacts to the many countries, which is especially valuable in reference to humanitarian projects, which is the future. That's a headline of the International College of Surgeons. So let me move along. I'm running short of time. Next one, please. Next slide. We'll talk just briefly about the International Museum of Surgical Science. Again, Dr. Arifins, others have referenced it. I'll go really fast. This is what the outside of the building in Chicago looks like. We have a huge statue out in front, Hope and Help. It's a very famous statue. And so next slide, please, and I'll go fast. Next one. The museum is a very key part of the International College, not only in the US, but around the world. I'm increasingly sending information around the world to all fellows about the museum. It is a success story in many respects. We have a wonderful staff. I give them the credit. And for the past 5 years, we have had a growth of in excess of 20% year over year. A couple of those years, we've had 50% growth year over year. So the museum we just announced a new grant that we got. I sent an email around to all ICS fellows. Hopefully you may have seen that, but we'll continue to communicate. Next slide, please. Next one, please. I'm running short of time, so I've kind of touched on this, and so we'll go to the next slide. We have, for example, just an interesting statistic. We have on the average at this time 40,000 people a year passing through our museum, and it's growing. So, and you think about the number of people per year coming through the museum and its growth rate, you understand what an important role it has for the International College of Surgeons, and it's the face of the college, if you will, in Chicago and around the world. We have a lot of international visitors, 13%, as you'll note there at the bottom. Next slide, please. Well, the journal we've talked about, and I just want to hit some high points. Professor Christopher Chin is the editor-in-chief, distinguished gentleman in Singapore. Associate editors are Dr. Is Healy, past world president for Mexico City, Professor Yek Hong Ho, Australia, Townsville, Queensland area, and Professor Georgia Soufas in Thessaloniki, Greece. The journal has a wonderful future. And next slide, please. In fact, it's been published since 1938. 1938, think about that, 80 plus years. And it's, as Dr. Arifins, I think, indicated, it's open access, only open access. We have set goals of when we receive an open access manuscript, we set a goal to have the peer review completed in 21 days and no longer than 30 days. We normally assign 2 or more peer reviewers to any manuscript that we receive. And then our goal, if it is peer review approved, to publish that within the next 60 days. So we are working hard on those goals, and the acceptance rate is right now 70%, rejection rate 30%. I think, frankly, it's a little too high as an acceptance rate. We should get it closer to 60%. These are statistics on publishing that maybe are not of interest to you, but I say that because our goal is, amongst other goals, is to increase the quality of the journal around the world. We had a difficult year in 2019. This year, the journal is progressing very well, and it's doing quite well now. So next slide, please, which is the end, and thank you, and I probably have taken a bit too much time, but I want to tell you in just a few words. You might ask me, what is the future of the International College of Surgeons around the world? And I don't have a slide for this, but I have a lot of conviction and sincere enthusiasm. The future of the International College of Surgeons is absolutely fantastic. It is a wonderful future. It's a bright future. And it's in part because of the cornerstone where we're progressing in humanitarian surgery. I always give credit to Professor Yekong Ho in Australia, who helped capture that thought. Professor Ali Kwan, who sponsored your work and has worked with you and Amban, and that is the future. It's a world that is in need of surgery of all kinds, and the need is great, and the more you give, the more you get back. And then on a financial basis, you have the journal and the museum that will sustain the college along with membership dues. So I've been here a number of years, and I'm not a surgeon, not a physician, but I believe and I'm enthusiastic about it. I get excited about talking about the college every time I'm invited. So this is a wonderful experience. I thank you, Professor Tahalele, Dr. Manopo, Dr. Arafans, Dr. Hermendy, the other leaders for giving me this opportunity. And I hope other people in the college around the world follow this example of your webinar. Thanks a lot.
Thank you very much, Mr. Max Downham, for your informative presentation. I appreciate that. For the next opportunity, I would like to invite Dr. Dwirani Rosmala Pratiwi, FICS, breast surgeon, to deliver her presentation. Dr. Dwirani, the floor is yours.
Thank you. Thank you, Dr. Peter, and thank you all of my teacher. Hello, Max. I'm Dwirani, but my friend called me Wiwin. I'm a breast surgeon in Surabaya Oncology Hospital. Good morning, all my seniors, teachers, and my colleagues. Thank you very much for the opportunity in this meeting, so I can share my experience in breast surgery. In this occasion, I also want to thank Professor Tahalele because he is my teacher. He is also my doctor because 35 years ago he operated my my ISD cardiac surgery. So now I can sit here and share my experience as a surgeon. Thank you, Prof.
Great for you. Great for you.
Thank you very much. I work on Surabaya Oncology Hospital as home surgeon since I been from the Erlangga Surgery Department residence in 2003, and now I'm a chairman of medical committee in my hospital. First, I want to talk about the history of breast surgery. We know that breast cancer is a very old disease, and the surgery has been done since William Halsted introduced a very radical surgery. But now the surgery become very, very minimal, and the very new study is about pathologic complete response of neoadjuvant chemotherapy. So maybe in the next future, surgery is not the part again of the breast cancer. I don't know, but and also the treatment of the breast cancer is not only surgery, but it is a multimodality treatment. So the survival will increase day by day. And now, because we have 5 modality of treatment of breast cancer, surgery, endocrine treatment, radiotherapy, and chemotherapy, it makes the survival rates increase very much. We know that in the first time that house that did the radical mastectomy, it is very high mortality. Survival rate, 5 years survival rate up until almost 90 is very, very good prognosis. Is very good news for all breast cancer patients. So the modern breast cancer treatment now, the aim of the modern breast cancer treatment now is to combine the multi-modality treatment, not only to give to treat the cancer, but also we have to hear and listen to the patient needs and preferences. So surgical is considered still the primary treatment, but the goal is not only to remove the cancer, but also we have to think now to think that we have to maintain the aesthetic breast form, because now saving the breast is very important for the patient. So modern breast surgery, referred as oncoplastic breast surgery now, it is the combination of optimal cancer removal surgery and then doing the plastic surgery technique to maintain or replace the breast shape. Oncology plastic surgery ranges from hidden the scar placement or simple breast remodeling to complex remodeling. And now we in Surabaya Oncology Hospital routinely do total breast reconstruction after mastectomy using the patient own tissue with latissimus dorsi flap or transrectus abdominal flap. Why it is very important to maintain the acceptable aesthetic breast form? Because patient now very, very scared when we give the bad news, you have the cancer, and then they will crying, and but when we said that you don't have to worry because you can keep your breast, and then they will calm down. So now immediate reconstruction surgery for breast cancer is very, very convenient for patient. It is less expensive because we limit exposure to anesthesia risk, and the aesthetic result tend to be better day by day by our learning curve, our breast surgeon learning curve, and the patient does not have to live with deformity, even if temporarily, because it is very hard when they saw their mirror, their shadow in the mirror, they have asymmetric breast. The importance of quality of life in breast cancer patient is very important, and we have to retrospective study, a small retrospective study in Surabaya Oncology Hospital. That result is it is statistically significant. There is a difference significant between female patient with cancer and healthy woman in terms of quality of life. It is more about their direct suggestion about body image and quality of life. Also, in very much there's a lot of research about this. That patient with mastectomy has a very low quality of life, and the recent study said that patient diagnosed with breast cancer that doing immediate breast reconstruction following mastectomy report a better quality of life, and importantly, the psychosocial, the sexual, and the physical well-being domains. So this supports the recommendation that we, the breast surgeon, have to discuss the option of immediately breast reconstruction with all our patients with selective, very selective indication. But we almost all of surgeons worried about how is the survival rate, or how is the recurrency rate of the breast cancer treatment if we not remove all of the breast. A lot of studies said that there are no significant differences in overall of disease-free survival rates when comparing breast conserving treatment and mastectomy. In breast conservation surgery, maybe the local regional recurrence disease rate is higher than the complete mastectomy, but in recent study, if we do the breast conserving treatment with a very tight, very high standard of patient selection, then the local recurrence will be very low. In Surabaya Oncology Hospital, we do the breast conserving treatment with the wide excision, and the local recurrence is very low here. If we do this procedure in the very small tumor. So as I said before, BCT, the local recurrence of BCT can be very low if we do the high standard indication for the patient selection, because the local recurrence rate will be higher if we do inappropriate patient selection. The tumor is too big or the breast is too small, and the very important thing is inadequate surgery. There are positive margins, and we let it. We are not concerned about the positive margin, and then the local recurrence will be high. Also, if we do the breast conservation treatment, we have to do the radiation treatment. It is I say it is a package of the breast conservation treatment, because if we do not do that, then the local recurrence will be high. Local recurrence also high in the biologically aggressive disease, like high-grade ductal carcinoma in situ, very big cancer with grade 3, or involvement of the skin, and the margin is not radical. So we have to do this procedure with high standard patient selection. I want to share about our experience in Surabaya Oncology Hospital. We have in average 500 new cases of breast cancer per year, with ages under 40 years old is between 5 until 16% per year. And since 1995, we have routinely carried out reconstruction with latissimus dorsi flap. It is about 12 cases per year, and take about 2 until 3 hours procedure. And since 2003, we have begun to tram flap from transrectal abdominal musculus reconstruction, on average 20 cases per year, with 4 until 6 hours procedure. And we do also the sentinel biopsy with blue dye marking. Here in Surabaya Oncology Hospital, breast surgery performed by us, general surgeon that trained in oncoplastic technique. We learned this skill in Düsseldorf with Dr. Mahdi Rezai. So we can offer immediate reconstruction with both therapeutic and economic benefits because we do not have to call our colleagues or plastic surgeon. So it's more cheap. Okay. Here is our patient in oncology, Surabaya Oncology Hospital, based on states that have been doing the surgery. So we have now the pathologic states. So we can see here that year by year, the patient with very early breast cancer is increased. So now we have approximately 30 until 40 young breast cancer. That's why maintain the breast shape is very important for us. We can see here also that stage 2E, second stage A is also high. The most of our patient is in second stage, and it is also can be done the reconstruction. So it is a must for us to do and to offer this option to the patient. So how we do all the procedure of the reconstruction. First, as I said before, the patient selection must be done very tight. So every Tuesday we have a multidisciplinary tumor board, and we discuss 4 critical elements in patient selection for breast conservation or breast reconstruction treatment there. So we tell the history of the patient and how is the physical examination, and then our radiologist will show the USG and the mammography and give to us the surgeon it is possible or not to do the conserving treatment, and the pathology will tell us about the pathology report of our patient that have done the surgery, and also we discuss there about adjuvant and neoadjuvant treatment and the evaluation of all of our treatment to the patient, and this is always document in the very neat documentation. In our practice, daily practice in doing the reconstruction or surgery, there are a lot of challenges. Mostly is about socio-cultural and economic problem. You know that reconstruction take a long time, surgery until 6 hours. So it is a very expensive procedure. And it is still challenges until now. That's why some patient we collaboration with BPJS Center. BPJS is our healthcare insurance, government healthcare insurance. So we can still do our service to the patient there. The challenge also about that triple diagnosis procedure is a must, and it is need very good approach, good communication from all the multidisciplinary specialists, and maybe in Indonesia it's very hard to meet this need, but thanks God in here in Surabaya Oncology Hospital we have done multidisciplinary approach tumor board since 1995. So until now maybe it's very routinely do here. Also, the challenges is in intraoperative cytology. For instance, we know that we have to do this surgery very clean. We have to make sure that there is no positive margin. So our pathologists here are very good. They have specificity and sensitivity results high until 98%. So it is very crucial to have the intraoperative frozen section examination. Our other challenges is long queue of radiotherapy. So if we do the BCT, then the patient have to wait long time for radiotherapy is also a problem. So that's why we do the very wide excision for our BCT. I want to show you what is the example of the challenge. In Indonesia, it is very hard for us surgeons to do the second surgery. So we have to complete the surgery in the first time in the very excellent result. So it is also a challenge. So learning curve is very important here. Here is I want to show you one of our patients that have a pendulum type of breast, and she didn't want to lose her breast, so we tried to do the surgery. We do the surgery with we take all the breast tissue and we replace the volume of the tissue with the latissimus dorsi flap. So here is the not all of our patient is excellent like this, but by learning curve, time by time we increase our skill. The other challenge is here the small breast, but she didn't want to lose the breast, and we try to do a very good cosmetic result of the cicatric. So here we do the BCT because the tumor is location is in the medial, and we do the latissimus dorsi flap to replace the replace the volume. Here also another challenge is if we do the central breast conserving treatment, and we try to tell the patient that we can do the nipple reconstruction, but then the patient didn't want to do the second surgery. So here's the result. But important thing that she said that the important thing is they can feel the bra symmetrically, and the patient is convenient with this. I want to the other challenge is to do the surgery for after the reconstruction after mastectomy. This lady have been done the mastectomy 8 years before, and once, and she was very suffer because she feel that it's very not confidence with herself. So he always come with crying, and then I offer to do the breast reconstruction, and here is the result. And then we do also the nipple areal complex reconstruction, and I think it is acceptable result, and the patient is very convenient with the result. The other challenge is if we have the very high tumor location, it is very hard for us to make a very good cosmetic cicatrix. So we have to try how to do the operation and still have best result for the cicatrix. And here's one of the example. Here's also the not very, but a big tumor and not too large breast, and we do the very wide breast conserving, a very wide excision of the breast tissue, and then we replace with the latissimus dorsi flap. This is the young lady. We operate her at her age 35, and now it's maybe 12 years ago, and she's still alive. Here's also firstly, we always take a large amount of skin, and the cicatric is very bad. So now we try to do the very small removal of skin, because in our study